The aintree intubation catheter has been designed for assisted fiber optic intubation and for uncomplicated atraumatic endotracheal tube exchange. The product is intended for use by physicians trained and experienced in airway management techniques. Standard techniques for placement and exchange of endotracheal tubes should be employed. A laryngeal mask airway, LMA, of size 2 or larger, or a cuffed oropharyngeal airway, COPA, is inserted into the patient's airway. This allows the patient to be adequately ventilated during the fiber optic intubation procedure. A bronchoscopic swivel adapter may be added into the anesthetic circuit, if not already present. Lubricate the fiber optic bronchoscope using either a sterile lubricant or sterile water. The aintree intubation catheter is mounted onto the bronchoscope and taped securely. The catheter should slide easily onto the scope. If it does not slide easily, there is a risk that the catheter may become jammed in the bronchoscope and cause damage. The distal 3 to 4 centimeters of the bronchoscope should extend beyond the distal tip of the catheter. This allows adequate tip deflection of the bronchoscope. The bronchoscope and aintree catheter assembly is passed through the side port of the catheter mount and advanced through the LMA or COPA into the laryngeal inlet. Be sure to direct the bronchoscope aintree assembly through the vocal cords and down towards the carina, while maintaining constant position of the aintree catheter. The bronchoscope is removed, leaving the aintree and the LMA or COPA in situ, while the position of the aintree is constantly maintained. The cuff of the LMA or COPA is deflated and then removed, leaving just the aintree catheter in the trachea. While the position of the aintree catheter is maintained, and by using the patient's upper incisors as a landmark, the endotracheal tube is advanced over the aintree into the trachea and positioned appropriately. The endotracheal tube is held in position, and the aintree intubation catheter is removed. The cuff of the tube is inflated. Ventilation is re-established, and the new endotracheal tube is secured in place. The bronchoscope is reinserted into the endotracheal tube to confirm its correct position.
The aintree exchange catheter really has changed our practice. We feel now much more confident and comfortable in the operating rooms, knowing that if there is a difficult airway, we can place a supraglottic airway device, knowing that we can actually go to endotracheal intubation very easily now. We've had great success, and now since we've been doing this so often with our residents and the faculty have been watching the residents, it's the go-to technique when we have a failed airway.